I think we can get started now. We have about 40 participants. Good morning, good afternoon, and good evening. My name is Deku Joele. I'm one of the senior epidemiologists from KNCB Tuberculosis Foundation. I'm coordinating this session from The Hague. This presentation will be on contact investigation. The main purpose of this webinar is to share lessons from both high and low TB burden countries from the TB programs in order to better integrate the ongoing effort to control both tuberculosis and COVID-19. So we have two presenters, two speakers today. This will be one of two series of webinars. This one is the first one, and we'll have another one on the 2nd of July. So we have two distinguished speakers, one from the Netherlands and the other from Ethiopia. My colleague from the Netherlands is Dr. Connie Erkens, who has a broad experience as TB control physician and as epidemiologist within the municipal public health services in the Netherlands. And she also worked for some years in Africa as a physician. So she currently leads a project that supports the Dutch National TB Program. And she also serves as the executive secretary of the Committee for Practical TB Control. Contact investigation is just one of her areas of expertise, which we really exploit today in these presentations. So she will be speaking about the lessons from the perspective of a low TB burden country, which is Netherlands, which will be followed by Dr. Ahmed Bedru from Ethiopia, who is the country representative of Ethiopia, KNCB Ethiopia. Dr. Ahmed is a pediatrician with more than 2 decades of experience in clinical areas, program leadership, as well as in research. So his talk will focus on Ethiopia's contact investigation experience, tuberculosis contact investigation experience, based on the work of the USAID-funded Challenge TB project, but we'll also touch upon COVID experience and also the projects implemented by other partners in Ethiopia. So just practical information, this will be a 1-hour session. We are already 8 minutes into it. We have two presentations, each will be about 20 minutes. And then that will be followed by about 20 minutes of Q&A. We'll try to respond to your questions as much as possible, but if we can't answer all of the questions in the 20 minutes, we will also send a written response to your questions, together with a 2-page summary of the discussions that will be shared in about 2 days after the presentations. And this session will be recorded for your information. So I would like now to invite Dr. Connie to take over the stage and start her speech. Thank you.
Yes, thank you very much, Deku, for your introduction to this talk. I will share my screen with the audience just in a moment. Here, and start my presentation quickly. This presentation is about what lessons can be learned from the long-standing experience with source and contact investigation in the Netherlands. Now contact investigation for COVID is recommended to contain the disease in countries where the COVID epidemic is wearing off. The experience with TB contact investigation in the Netherlands demonstrates that with systematic and thorough contact investigation, TB transmission in the Netherlands has been contained in the past decades. I hope this, how to move my screen. Yeah. So as you can see from this slide, the number of TB patients in the Netherlands has decreased steadily in the last 2 decades, despite some temporary increases due to the influx of migrants from high burden countries. The TB incidence in 2019 was 4.8 per 100,000, an all-time low, at an all-time low point. And we had 759 patients in that year, and about 3/4 of the TB patients were of foreign-born origin. This means that in the Netherlands every day 2 to 3 TB patients are diagnosed, and for about 2 of these patients have infectious TB requiring contact investigation. In comparison, the number of reported COVID cases has been and still is overwhelming in the world. It's on the, as you can see from the graphic on the left side. In 6 months' time, the number of reported cases equals the annual number of TB cases estimated by the WHO of 10 million. In the Netherlands, we had nearly 50,000 COVID cases reported until 2 days ago. But as you can see here on the left side, on the right side, the epidemic has now worn off to the daily number of 64 or 2 days ago. And that means that we are in the Netherlands, we are in the stage of containment. And contact investigation is feasible, and other measures can be relaxed, as was actually proclaimed by the government yesterday again. There are many similarities between TB and COVID, but there are also many differences, and there's not enough time to go through these differences in detail. But what it boils down to is that what the diseases have in common is that both COVID-19 and pulmonary TB cause respiratory symptoms. TB and COVID spread by close contact between people, although the mode of transmission differs slightly from airborne versus droplet infection. Both diseases have a prodromal and subclinical stage when infectiousness is possible, and both diseases can cause outbreaks in households, workplaces, or other congregate settings. So early case detection is the most important intervention to reduce the risk of TB, both the risk of TB and COVID-19 transmission. The goals and objectives of source and contact investigation is to stop transmission and morbidity and mortality, and that is enabled through early case finding and creating awareness among the contacts. And that goes for both TB and COVID. From our experience with TB contact investigation, we know that among contacts, we find between 1 to 5% TB disease, so that's really a high prevalence, and 10 to 50% of contacts infected with TB. And those who are infected have a 10% lifetime risk to develop active TB. 80% of them do so in 2 to 5 years. Now in TB, we have the option of giving a preventive treatment which can prevent progression in 70 to 90% of the cases, depending on the regimen provided. For COVID, the prevention is actually in the quarantine and self-isolation that will prevent further transmission and at least early detection of the disease. One of the most important lessons from TB contact investigation is that the success of the intervention is directly related to the compliance of both the patients and the contacts with the recommendations around the contact investigation procedures. And that means that patients should be in perfect understanding of what is happening and what is being done, and that for both patients and contacts, there should not be any barriers to follow those recommendations. That means that guiding principles for contact investigation are that it should be integrated on a community level. For TB in the Netherlands, we can achieve that because we have a nationwide network of local public health services providing the contact investigation services. It's also the way it's being done by the health services is it's people-centered, it's outreaching, and the nurses who are coordinating the contact investigation are well trained to avoid stigma and preserve confidentiality. And they know that clear communication with patient and those exposed is key. This is a quite intensive and time consuming process. And in order to make it sustainable and affordable, it means that you have to target those who are being examined effectively. In contact investigation, we use the stone in the pond approach to do this targeting. And I'll explain more about that later on in this presentation. And the last thing is, which is important, is that there are no costs for contacts involved. It means screening is free of charge, and treatment, if it's offered, is covered by health insurance. Now, these guiding principles, to my view, can also be or should also be applicable for COVID-19. Especially, I think the first, although the screening in the Netherlands is also free of charge. When source and contact investigation is indicated for TB around infectious TB patients who are able to transmit the disease, that's obvious. There is also an indication for investigation of contacts of childhood TB patients or young adults with a known source. This is what we call source investigation. But it means that in practice, contact or source and contact investigation is not always, does not always need to be performed around all notified TB patients. And in fact, in the Netherlands, it's done around about 60% of the notified cases. That's different with COVID. In COVID, you need to do contact and source investigations around all cases because you want to reach all the contacts of those cases, and it's going fast. I already mentioned that TB, in TB, we follow the stone in the pond approach. It enables targeting the contacts with a real risk of exposure. And I will explain here how that works. Initially, contact investigation is started among close contacts. And they are defined as either persons who are in the household of a TB index case or those who share an enclosed space with the index patient for extended time periods during the presumed infectious period. And for TB, that can be for a long time, for some patients even longer than a year. For practical purposes, we usually go back 3 months in time and then see whether other earlier contacts still need to be identified. What is important is that in this, vulnerable contacts have a high priority. And here in this schedule, you can see how this definition of close contact is operationalized. It's a combination of the duration of the contact and the setting where the contact took place. So it could be in a small, badly ventilated environment such as a car, and then you need a short duration is already enough to be classified as a close contact. So then up and for in a room daily or more than 8 hours is also still enough to be classified as a close contact. And in real infectious patients, those who have a little bit shorter exposure in a small enclosed area are also regarded as close contacts. So these three would be targeted for the first examination round. For other exposed contacts, so which we call casual contacts, they may be targeted when we find evidence of transmission among close contacts. And to show that this is works, you can see here some data from the Netherlands where we analyzed the infectiousness and the transmission of patients based on the results of contact investigation. And it shows that among sputum positive patients, there 60% of the contacts were found with either TB or latent TB infection. And in lesser infections patients, it is a lesser proportion of the patients are found with either TB or LTBI. That means that in 1 in 3 of the potentially infectious sputum smear positive patients do not cause transmission, and then it is certainly not necessary to scale up to other casual contacts for an examination. When you examine contacts, you do that with a certain algorithm. In the Netherlands, we use a symptom check for all contacts. Those who do not have symptoms are checked with an LTBI test, either tuberculin scan test or IGRA. And those with a positive test are also examined by chest X-ray. People with symptoms are directly examined by chest X-ray as well. If we compare this to COVID, I got this from the guidelines from the Dutch CDC, the RIVM, and these stipulate that a more or less similar approach of categorizing close and less close contacts, and they categorize a close contact as also a person who is in the household, but can also be a person who's been within 1.5 meter in an enclosed space with index case or had direct physical contacts, and this for 2 days prior to the onset of symptoms. And there's a slight mistake in this slide because the physical contact doesn't have a time the 50 minutes they don't go for physical contact. For this group, also vulnerable contacts are prioritized for examination. And in this case also, when there's evidence of transmission, there's more reason to Oh, that's not quite clear from the guidelines. If that's a reason to step up, but how these COVID contacts are checked for symptoms as well, just as TB patients, and those with symptoms are examined with a nasal swab or oropharyngeal swab. For at least twice, and if it's negatives, they are asked to self-isolate for at least 14 days and to report themselves when they develop symptoms. I want to take you a step back to the moment for where to identify close contacts eligible for examination. The distinction of the Dutch guidelines for tuberculosis and other, I think other low burden countries from guidelines for high burden countries is that from the start, the identification of contacts goes beyond the household. All possible sites of transmission are taken in regard, whether it's a workplace, school, or leisure, place of leisure. Because people may be spending more time at other places than they actually do at home. As this might be clear, for instance, from this picture of these two youngsters as classmates who are sharing the same table in their class, and they might be spending the full day together where they don't see their parents that much. So collecting information for contact investigation and identification of the contact is really the most crucial step in contact investigation. It's essential to collect correct and complete information needed. In TB, we advise nurses actually do visit the patient's home and the workplaces or other places where transmission could have taken place to get a clear idea of what the risk of transmission in that situation could be. And as I said, it is very important that the index patient understands this and knows what the goal is, and that the index patient is motivated to disclose his activities and the contacts as well. Informing and motivating the patient is key. And this with respect to individual concerns of the patient and respecting the privacy of the context as well. Only if this is done correctly and you will obtain the right information to determine the degree of exposure for the contact. And here, this slide also shows an important difference between contact investigation for TB and possibly for COVID. Because of the relatively long incubation period, the best time to determine in context, a TB context, to determine if they are infected is 8 weeks after the last exposure. And that's usually the time of diagnosis of the index patients. However, because TB patients may also have been infections for quite a long time, as I said, sometimes longer than a year, secondary TB cases may have already developed. And that means that that in these cases, people with a long diagnostic delay, a first examination to rule out active disease among symptomatic contacts and vulnerable contacts is very important. So you actually need 2 moments of examination in these cases. Moreover, in vulnerable contexts, you can use the first contact also to offer prophylactic treatment to prevent their progression to TB if they are infected. For COVID, there's no delay in timing of the examination. You want to act as fast as possible and approach contacts preferably within 24 hours or 48 hours. So coming back to the stone in the pond approach, when to scale up contact investigations in other contexts, I said that's before, that you do that only when you find proof of transmission. And what is proof of transmission among TB? Those we consider contact with active disease detected, young children with a positive skin test or IGRA, contacts with known skin test or IGRA conversions. And in the Netherlands, we also can use the observed prevalence of infection and compare it to the expected age-specific background prevalence. And we can do that because we have a low background prevalence of TB infection in the Netherlands. It's approximately 2% among the general population. So, but in high burden countries, this is obviously not possible. Now I want to show you a case history that might illustrate better how the stone in the pond method or approach works.
Can you move a bit faster?
Okay, okay. I should. Okay, yeah. There's. Sorry. This is a man who was found with infectious TB, and you can see here that that he lives with his father, but he also has other daily activities, and he attended a healthcare center quite often because he had was not feeling well for a long time. So a lot of contacts were identified, of whom some were in all areas. There were some in the first ring, second ring, and third ring. Here you see how that is worked out. Here you can see that this would normally be regarded as household contacts, especially these two. This is the father, he was infected. Here you see that the first ring in the coffee shop, there were quite a number of people infected. That was the reason to extend the examination to the second ring. And here you see that in the coffee shop, more people were found to be infected than actually in the second ring of the household. And then in the snack counter where he frequented, there were also more people to be infected. Actually, they did a third ring, and you see in the third ring there were only few people infected. And this was a person with immune suppressive disease. And this appeared to be a person who was infected unrelated to this case. So just a few slides about monitoring and evaluation. In the Netherlands, we have systematic monitoring and evaluation of contact investigation. It's it's done through our notification system. We have monitoring indicators which look at coverage of contact investigation per index case, the cascade of care for contact investigation, and the occurrence of serious adverse events. This is here the last report. The results of the last report showed that 90% of the cases a contact investigation is done. Cascade of care shows that 86 of the eligible contacts are reached for examination. Prevalence detected is 2% of TB cases and 16% average LTBI cases. 81% of contacts identified with LTBI are started on LTBI treatment, and 86 of them complete the treatment. And the occurrence of serious adverse events is higher among those with TB treatment and reasonable among those who receive LTBI treatment. So what can we learn from TB contact investigation to contain COVID? We learned that risk assessment is important to identify close and vulnerable contacts, and the lessons which can possibly be learned from TB for COVID are the best practices how to reach vulnerable contacts among the contacts. Communication with patients is very important. It should be done as soon as possible, and avoiding stigma and education of the patient is key. For communication with other stakeholders is important. We find it is very useful to develop standard operational procedures and information education materials to explain the scope and proceedings for these groups, and that's the same more or less for contacts. And as I said, monitoring and evaluation is also important, so that you can ultimately improve the effectiveness and the level of implementation of the intervention. This was my last slide. I don't think there's any time left for questions, so I give the floor back to you, Diego.
Thank you. Thank you very much, Connie, for this comprehensive and very insightful presentation. We'll have questions on the chat, so you can respond to the questions already. So there are a couple of questions. So may I ask Dr. Ahmed to take the floor?
I'll try to get myself read. I stopped sharing, sorry.
Yeah.
Yeah.
So Connie, there are a few questions for you.
Sorry, yeah. That's a quite complicated question. I'd really have to look at the slide for which he's referring to. So maybe it's better to move to the next question, which is about is actually about the COVID contact investigation. And I think it's good to stress that this presentation I just gave was actually about our experience with TB contact investigation and why some of the choices have been made. What I report about COVID contact investigation is from the guidelines of the Dutch CDC, and why those choices have been made. I cannot, it's not really within my experience to answer those questions, and I think we will go into the reason behind that in our next seminar. So, but obviously, the incubation time of COVID is extremely short, and you want to it's only 2 days, so you want to inform people as quickly as possible to be sure that they are aware of the risk they have taken, and that they self-isolate or go into quarantine, and thus way prevent transmission. So that's my understanding of that the 24 hours recommendation.
Okay. Okay, thank you very much. So Dr. Ahmed, I'm sharing on behalf of you. So Dr. Ahmed, this is your turn. Dr. Ahmed?
Can you hear me now?
Yes, do you see the slide that I shared?
Yes.
So I will project it for you. So go ahead and present, please. You have 15 minutes.
So other screen sharing, do you want to continue? You will stop other screen sharing.
No, I shared for you. So continue. So this is your outline, please.
Okay, sorry for the system. I'm presenting about our contact investigation experience from Ethiopia. As you know, Ethiopia is one of the 30 high burden countries with an estimated all form of TB of 151,000, 100,000, and MDR TB incidence of 1,600, and mortality 24,000. So my outline of presentation is I'll talk about all background of contact investigation implementation in Ethiopia, and the intervention, and a few points about COVID. Probably I may not go to that level because already it was mentioned by Connie. So what we learn from TB COVID integration. So as you know, when we define contact investigation, it is a systematic evaluation of individuals who have contacts, potentially infectious tuberculosis cases within 3 months of TB treatment initiation. Basically, contact investigation aims to identify contacts of all age with undiagnosed TB, provide preventive therapy for eligible contacts when we say that they don't have TB. So in general, contact investigation helps us to improve the case finding by focusing on high-risk groups, and also helps us to reduce transmission. And in addition to that, we have to make sure that those who have latent TB infection are getting the appropriate treatment. And finally, it will also help us to reduce the burden of TB in the health system. As you know, contact investigation is also one of the diagnostic means for childhood TB. Because when we identify a child with contacts, additionally, if he has any sign and symptom of tuberculosis, that will be a very strong point. What are the eligibility criteria for contacts in Ethiopia, in developing countries? If any person who have contact with pulmonary tuberculosis or presumptive or confirmed they are TB will be eligible. So we have to do contact screening for those who have features of TB, those children less than 5 years. Currently, even this age is extending after the new LTBI management. Those who have compromised illness like HIV, those from high-risk congregate setting like prison, homeless shelters, and so on. Next slide. I think this definition is also touched by Connie. Anyway, when we say contact is any person exposed to someone with infectious tuberculosis, either it can be a family member, household mates, or a coworker anywhere. So the main group of contacts are households, especially in developing countries. And there are also other close contacts which they share common space, like gathering place, work facilities can be also considered as close contact. As you know, nowadays the definition of close and casual is interchangeably used. So there are casual contacts are those who have contacts just outside this sphere of line. When we see the contact investigation implementation in Ethiopia, historically, contact investigation implementation was started early in 2012, immediately following the coming up of the WHO guideline on contact investigation by USAID TB project. Subsequently, there was also work by Reach Ethiopia through the TB Reach funding, and they conducted the contact investigation in 2013. Subsequently, the USAID Challenge TB project expanded the contact investigation starting from 2016 until the project ended in 2019. It means a total of 4 years, an extensive contact investigation work was done. Following this effort and activity, contact investigation was taken as one of the, it was also adopted, the indicators are adopted and taken by in HMIS, and the register also developed for that. Contact investigation also included as a case finding strategy in the guideline. Additionally, to make the work unified, and systematic standard operating procedure for contact investigation was developed. So the next slide will show us, next slide. Yeah, this is the first one. The red one is the SOP for contact investigation. The next one is the register, which is used. So now what it means is that contact investigation is well integrated into the national system, and it is becoming a reportable disease with 2 indicators. The key steps for contact investigation in Ethiopia is the first thing is we have to do a clinical review, a review of the clinical document of the index case. Then we do an interview, and then stratification using basically the Stony Point principle. But basically, most of the time, this is not really well practiced. We really focus more at household level. But ideally, this is really the direction. Once we identify the contact, we need to do screening, and then if necessary, using the screening will done usually using symptomatic screening. Then we can go ahead and do clinical and medical evaluation, a laboratory investigation, and if the contact does not have TB eligible for LTBI management, we'll put the patient with a child or the contact on LTBI management. If there is TB, then it will be treated accordingly. This is what we mean the stratification using the Stony Point principle. So you have the contact, the index case, then you focus more first on the household, and then you can consider the close contact, and then just go out and to identify those casual contacts. So this is a stepwise stage of contact tracing. So this is really in principle a very important step of doing contact investigation. In Ethiopia, contact investigation is done at 3 levels: at health facility level, at community level, and also congregate setting. In addition, the administrative level of implementation is a very important component of the contact investigation work. The next tables will show us, next slide, what are we doing. For example, at health facility level, the key activities, the index case identification, contact tracing, screening, then investigating presumptive TB, treatment if there is TB, education. If it is the contact has no TB, then eligible for preventive therapy, you go on and do preventive therapy, and subsequently the follow-up will be done. This is usually done by TB focal person and extension workers, and capacity usually developed. Partners are really playing a major role here, doing supporting mentoring and other activities. Next slide. At community level, the contact tracing is done at home. This is where the congregate setting intervention also comes as part of the community intervention. Then referral of contact to health facilities, health education, and as the same way, if there is a preventive therapy, we just go and do preventive therapy, and subsequently the patient follow-up screening will be done. Usually every 3 months, doing follow-up screening is very important, especially for those who have MDR-TB contact, because we don't have a prophylaxis therapy for DRTB contacts. The third stage, which I said, is the administrative level. This is mainly routine registration of the recording of contact investigation, conducting quarterly supportive supervision, review meeting, catchment area meeting, to make sure that things are really going very well. So this is done at the responsible parties at a higher level, with significant support from partners, both financially and technically. Next slide. There are other forms of contact investigation. We call it reverse contact investigation. Is, for example, if we identify a child with TB, then we just go to the family to trace those cases, where is the source. So this is one of the modality of contact investigation. The retrospective is, as you know, in Ethiopia, the contact investigation is not started well, and it is reached to a national level. So there are previously treated patients. So those backlog of patients, it can be 3 years or 5 years, will be identified, and the list will be provided to health extension workers, to their respective health posts, and house visit will be done. And then once we identify the presumptive, the TB case, then the contact screening will be done accordingly. So this is another modality of contact investigation we implemented during the project live. So the next slide. After all this intervention within 4 years period from 2016 to 19, with the USAID Challenge TV program, a total of 66,000 index were identified. More than 200,000 households were screened, and a total of 1,113 cases were identified, which is 0.5%. When you see it with according to the case notification nationally, it is almost 513, which is 3 times higher than the national incidence. There are some contact investigation experience also, which really showed even a higher level of close to almost 10 times higher. Okay, next slide. This is to show you the IPT coverage. And so the red one showed you the IPT coverage for those under 5. Every quarter starting from 2016, it really increased significantly. And those started on IPT also showed significant improvement. And by the time the project is completed, it almost reached to 72%.
Dr. Ahmed, I think you have to be very fast in this area now because we are left with 8 minutes.
Yeah, I think I don't have to go to this area because the principle of COVID and contact tracing is already addressed, and the principle is almost similar with what Connie presented. I think we can pass this slide. I can go to the next one. The definition of contact investigation is also, those who we call them contacts is also the same. So the next slide, I think we can go to the next slide. The next slide is when we talk about COVID, the COVID situation can be divided into 4 transmission or epidemiologic scenarios. So for each epidemiologic scenarios, we can come up with a very good contact tracing strategy. For example, if there is no case at the country level, a well-trained contact tracing workforce should be identified, trained, and they have to be ready and stand by to respond to first cases. In a sporadic cases or clusters, in which imported case with limited local transmission, we have to do exhaustive contact tracing for rapidly suppressing the transmission. The third group, when there is a cluster of cases, it means there is increased imported local transmission, but it is still linked to known chain of infection. Then we have to do strong contact tracing is essential to suppress the transmission. Next slide. The fourth transmission epidemiologic scenario is when there is a wider community transmission. In a situation in which the transmission is wider, it's very difficult to do a broader or wider contact tracing. Therefore, the contact tracing has to be really focused, and it has to address households, healthcare workers, high-risk closed settings like dormitories, and other vulnerable groups. In addition to that, contact tracing is very critical when we are able, when we pass through the peak of transmission and the cases are decreasing, to really keep the level down and to monitor the disease transmission. Still, we need a very strong contact tracing strategy. Okay, so in general, these are the 4 major scenarios. So countries can be in any of the scenarios, or one country may have all the scenarios. When you divide the country per district or region, all scenarios can be in the same country. So what are the steps? I think we don't, the steps, I don't have to go. Contact identification, contact listing, and contact follow-up, and finally we'll discharge the contact in terms of COVID. So the last one, the next slide is, in general, what do the 2 diseases have in common? This is already mentioned by Connie, so I don't have to repeat, so I will go to the next slide. Next slide. Lesson, what is the lesson from the TB program? Lesson learned over many years of TB infection prevention. As you know, TB program has a long history. Contact investigation was done almost for the last minimum 8-10 years. So this effort will benefit to stop the spread of COVID. The steps involved in contact tracing, especially the Stony Point principle, if it is properly applied, is really a good strategy to control, to do contact tracing in COVID. And the other thing is, as you know, currently the COVID situation may last long with, as compared with other similar outbreaks. So it needs a strategy, a longer term strategy like tuberculosis. So we have to give a due consideration and come up with a very good contact tracing strategy for each epidemiologic scenario and for a period in which the disease is suppressed. So we need different strategies. So this is what we can learn from TB. In addition, next slide. As you know, the TB program staffs with their experience and capacity, including contact tracing, infection control, they are really well placed to share knowledge, expertise, and provide technical and logistical support. So this is really a very important area to consider. In addition to that, the network of laboratories established for TB in so many countries, including the gene expert, will be leveraged to respond to COVID epidemic. So I think this is my last slide. And thank you very much.
Thank you very much, Dr. Ahmed. I would also like to thank the participants for their patience with our slightly longer presentation. We are left with just 2 minutes. I don't think we have much time, but as I promised, we will summarize this presentation in a 2-pager, and we'll send it to all of you through your emails that you provided in your registration. But we have 2 minutes. Ahmed, if you have, or anyone from KNCB or from elsewhere, if you'd like to make one comment or some suggestions, you can raise your hand.
Yeah.
I think we just have a question in the Q&A right now about, for Dr. Ahmed, do you use full PPE during COVID-19 contact tracing?
Yes, definitely. That's very important. We use that. That's also the practice at the country level.
Yeah, thank you. Thank you, Rachel. So I think, so just to recap this in 1 minute, I think the principles of conducting good contact tracing are the same in both countries, irrespective of the magnitude of the problem, the integrated approach, the people-centeredness, focus on sustainability and affordability, issues related with cost. They are also central to, I think, to the contact investigation experience in both countries. Additional lesson that we hear from Ethiopia, the stepwise approach that we have used in order to bring it to the national level and to make it a national guideline was, I think it was very helpful. But what I also noticed from this presentation is that when we started preparing for this webinar some weeks back, we were still talking about learning from the TB program, but we also have now extensive literature and experience from the COVID contact investigation. I think the learning has now started to be two-way. So in our next webinar, I think we'll talk more, how we can learn from each other and how we can make, end these diseases. I don't think we will continue to live with tuberculosis for many years to come. And I don't think we'll also keep, COVID as a problem in this world. So thank you very much, everyone, for your patience, for your attendance, and we'll keep in touch through our emails. And so I would like to end this session now. Thank you very much.
Thank you very much. Thank you all.